We're going to be talking about cardiovascular disease and exposure to smoking. Cardiovascular disease, or CVD, is a broad category of diseases affecting the heart and blood vessels. These diseases are often driven by processes like buildup of plaque in the arteries or long-term elevated blood pressure. CVD can lead to major health consequences, including heart attacks, strokes, and reduced blood flow to vital organs and limbs. The term CVD covers many specific conditions. Some of these conditions involve coronary artery disease, hypertension, and pulmonary artery or peripheral artery disease. These conditions are interconnected and consequently represent a major global health burden of CVD. The three specific types of CVD that we might mention during this presentation are hypertension, which is high blood pressure and is a major contributor to cardiovascular disease because of the long-term elevated pressure that damages blood vessels and vital organs. Key contributors to this disease include smoking, high salt intake, inactivity, obesity, alcohol use, and age. Lifestyle changes and medications are essential for reducing blood pressure and preventing CVD. Coronary artery disease, or CAD, is the most common heart disease and occurs when plaque buildup in the coronary arteries reduces blood flow to the heart. It can weaken the heart over time and lead to heart failure. Risk factors include obesity, inactivity, unhealthy diet, smoking, and family history. Treatment also includes lifestyle changes, medications, and sometimes procedures to restore blood flow to the arteries. One literature that we reviewed was a study that is the largest study of diverse U.S. Hispanic and Latino adults and provides detailed heritage-specific data on CVD risk factors. For smoking, the study reported overall current smoking rates higher than older national surveys. Puerto Rican and Cuban heritage groups show particularly high smoking prevalence, and for some subgroups, high smoking intensity, both critical for elevated CVD risk. Smoking rarely occurs alone, and in this study, most adults had at least one other adverse CVD risk factor. This tends to suggest that the prevalence must consider social and cultural context. This supports strategies that are heritage targeted and culturally tailored, focusing on smoking cessation alongside management of other CVD risk factors. Another study that we reviewed was smoking patterns in the Hispanic and Latino population that vary a lot depending on subgroup. Puerto Rican and Cuban adults consistently show the highest smoking rate, while Mexican adults tend to have the lowest. Even though Hispanic smokers often smoke fewer cigarettes per day, they experience higher levels of secondhand smoke exposure, according to the study. The Hispanic Community Health Study and study of Latinos also showed that cardiovascular risk factors like hypertension are already fairly common in this population, and Puerto Rican adults have the highest clustering of these risk factors. This means that when smoking is added on top, the overall CVD risk burden becomes even higher. Next, past studies of myocardial infarction suggest that something called the smoker's paradox, where smokers appear to survive heart attacks at a higher rate. However, more recent studies using modern treatments do not support this paradox. The study that we reviewed covered nearly 1,800 patients and found no significant difference in 1 year mortality between smokers and non-smokers. This matters for our project because Hispanic and Latino adults are underrepresented in these types of analysis. Given the subgroup variations in smoking combined with socioeconomic factors and access barriers, we don't actually know how smoking influences cardiovascular disease in populations using real clinical data. That's why our retrospective cohort study is important. It helps fill in the gaps of literature by explaining how smoking relates to CVD diagnosis in Hispanic adults in the real-world primary care setting. Our primary research question is, how does smoking, current and past, influence the risk of developing cardiovascular disease among Hispanic adults receiving primary care? Our aims are we want to measure the burden of cardiovascular disease in our study population. We're looking at Hispanic adults aged 18 to 85 who visit 6 primary care clinics from 2020 to 2025. We stratify that these findings by smoking status, current smokers, former smokers, and never smokers. This aim helps establish a baseline pattern and understand how common CVD is across different smoking groups. Our second aim focuses on evaluating how smoking influences the risk of developing CVD. We will examine whether current or past smoking increases CVD risk in Hispanic adults, analyzing how adjusting for key factors such as age, sex, insurance type, zip code, and social determinants of health will affect this. Adjusting for these variables help isolate the true effect of smoking on CVD risk. Our goal is to determine how strongly smoking is associated with CVD using measures like relative risk and adjusted hazard ratios. Our reference population was defined using several key filters to ensure consistency and relevance in our research question. First, only individuals who report that they are Hispanic ethnicity were included. The age range was restricted to adults of 18 to 85 to help capture a broad adult population while excluding pediatric and extremely elderly patients that might introduce additional variability. To ensure adequate clinical information from these patients, individuals were required to have at least one visit per year to any of the 6 primary care clinics. Smoking status, a key exposure variable, was determined using multiple data sources within an electronic health records. Subject identification for this study based off of their utilization of primary care services as mentioned above. Eligible individuals were required to have at least one primary care visit, and the study population included men and women, allowing for examination of cardiovascular risk factors across genders. Subjects represented a range of smoking histories, and participants reflected diverse socioeconomic backgrounds, allowing for assessment of contextual factors that may influence outcomes. Our planned sample size for this study was planned to be quite large and are using 5 years of ERHR data. These clinics have a high patient volume and we expect large sample sizes. Our estimated sample range from about 1,400 to over 3,500 Hispanic adults. A sample size of this size will allow us to compare every smoker and never smokers and detect meaningful differences in cardiovascular disease incidences among these groups.
We will be conducting a retrospective cohort study by looking at retrospective electronic health records of the Hispanic population who visited 6 primary care clinics of the Health First Midwestern healthcare system in the United States for biannual checkups between January 2020 and January of 2025. These are patients between the ages of 18 and 85. These patients will be pulled from the electronic health record system by the health systems data analytics team. We will also request that the analytics team flag patients with a diagnosis of cardiovascular diseases using ICD-9 and ICD-10 codes, and patients that self-report as smokers or had smoked in the past. The social determinants of health screeners embedded in the patient health records and administered during the healthcare visits will also be used to determine the patient's socioeconomic status and secondhand smoke exposure. We will also use insurance information to identify if the patient is publicly insured, privately insured, or has no insurance. The reasoning behind our selection. Hispanic men and women will be focusing mainly on how smoking plays a role in the diagnosis of CVD in Hispanic men and women. The ages that we chose, the age range we chose, which we had chosen to provide a wide range of ages to study risk exposure and disease progression in different age groups. Our source, we chose to use the electronic health record system to obtain retrospective data because it will be less prone to bias. And the questionnaires, this will help us understand the risk behavior of smoking and social factors that contribute to it. Next slide. Thank you. Eligible participants will first be analyzed as a defined population for the first year. And then the population will then be further split into two separate groups and analyzed for 2 subsequent years. And then further split into 4 study groups and analyzed for 2 years, making a total of 5 years of retrospective follow-up. Although we already know the outcome, analyzing the data at varying stages is important as this helps understand risk exposure and disease progression. Next slide. Thank you. So the defined population, inclusion criteria for the defined population includes Hispanic men and women, ages 18 to 85 at the time of analytic poll. There's a data analytic poll, has had at least one visit per year at 6 specific primary care clinics of the Health First healthcare system between January of 2020 and January of 2025. Exclusion criteria include not Hispanic, outside the age range of 18 and 85 at the time of analytic patient data pool, has had no recorded visits to the 6 specific primary care clinics of the Health First healthcare system between January of 2020 and January of 2025, and has had a year without any visits to any of the 6 primary care clinics of the Health First healthcare system between January 2020 and 2025. The exposed population. This population was selected from the defined population. The inclusion criteria for this population includes self-reported smokers at some point or another. Exclusion criteria for this population includes self-reported non-smokers. The not exposed population includes this population will be selected from the defined population, and the inclusion criteria for this population include patients that do not smoke, and the exclusion criteria for this population includes self-reported smokers. For the diseased and not diseased population from the exposed population, for the diseased population, it will be pulled directly from the exposed population, and inclusion criteria would include patients that have a diagnosis of a CVD and are self-reported smokers. Exclusion criteria would include patients that do not have a diagnosis of a CVD and do not smoke. The no disease population will be selected from the exposed population, and the inclusion criteria will include patients that do not have a diagnosis of a CVD. Exclusion criteria would include patients that have a diagnosis of a CVD and do not smoke. And the same thing for the not exposed population. The diseased population will be selected from the not exposed population, and inclusion criteria would include patients that have a diagnosis of a CVD and do not smoke. And exclusion criteria would include patients that do not have a diagnosis of a CVD and are reported smokers. The no disease population, this population will be selected from the not exposed population, and inclusion criteria would include patients that do not have a diagnosis of a CVD and do not smoke. The exclusion criteria would include patients who have a diagnosis of a CVD and are self-reported smokers. The variables which we chose for the following reasons. So our age group, this age range was chosen to provide a wide range of ages to study risk exposures and disease progression in different age groups. Smoking status, to help us differentiate between those who are exposed to the risk and those who are not. Secondhand smoke exposure, to help us understand the effects of secondhand smoke with CVD diagnosis in the study population. Zip code, to understand the relationship between patient geographical location, and smoking habits or patient's exposure to the risk. Insurance information to understand the relationship between patient's healthcare management, smoking habit, and the diagnosis of CVD. CVD diagnosis is our disease of interest.
This proposal focuses on several interconnected factors that may be associated with the development and progression of cardiovascular disease among Hispanic Latino adults. These include traditional biological factors such as hypertension, diabetes, dyslipidemia, obesity, and smoking, all of which disproportionately affect many Hispanic subgroups. Psychosocial and sociocultural factors such as acculturation, chronic stress, cultural obligations, discrimination, migration-related challenges, and limited access to healthcare. Gomez identifies these factors as uniquely influencing cardiovascular risk among Hispanic communities. The risk underestimation, as standard pooled cohort equations may misclassify CVD risk in Hispanic adults, potentially delaying early detection and prevention. Collectively, these factors create a multidimensional risk environment that shapes CVD incidence, severity, and outcomes in the Hispanic Latino population. CVD is the primary outcome because it represents a major global public health burden. The World Health Organization reports that 19.8 million people died of CVD in 2022, accounting for 32% of all global deaths. CVD is largely driven by modifiable lifestyle-related risk factors, including tobacco use, unhealthy diet, obesity, physical inactivity, excessive alcohol consumption, and air pollution. Rodriguez and Bloomer emphasized that CVD is also the leading cause of death among Hispanic adults in the U.S. However, risk is frequently underestimated due to prediction model limitations and lack of culturally specific research. Wiley and colleagues documented substantial rates of myocardial infarction, stroke, and cardiovascular mortality among diverse Hispanic subgroups, while Rodriguez and colleagues note disparities in rare delayed diagnosis and poorer outcomes. The study incorporates several safeguards to ensure ethical, confidential, and high-quality research practices. Confidentiality. All collected data will be encrypted and stored in password-protected files. Participant identities will be protected using coded ID numbers instead of names. Only authorized research personnel will have access to the linking file containing identifiable information. For participant risk, the study involves minimal risk as data collection relies on surveys, electronic health records extractions, or pre-existing datasets. No invasive procedures will be conducted. Participants may withdraw from the study at any time without penalty. For data quality, validated instruments will be used to measure psychosocial factors, acculturation, and health-related behaviors. Research staff will undergo training in culturally competent data collection and bilingual interviewing to ensure accuracy and participant comfort. Next slide. The study will use several analytical techniques to accurately evaluate cardiovascular risk in Hispanic Latino populations. Descriptive analysis will calculate the prevalence of CVD across Hispanic subgroups. These analysis will also describe the distribution of behavior, biological, and social risk factors. Adjusted statistical models, logistic regression models will examine dichotomous outcomes such as the presence or absence of CVD. Count models will evaluate outcomes involving event frequency such as hospitalizations. All models will adjust for age, sex, socioeconomic status, language, healthcare access, and acculturation to reduce confounding. Sensitivity analysis will determine whether atherosclerotic cardiovascular disease pooled cohort equations underestimate risk in Hispanic populations, as noted by Flores, Rosario, and colleagues. Stratified analysis will be stratified by sex, national origin subgroup, and acculturation level, following the recommendations of Gomez and colleagues. Stratification helps reveal meaningful subgroup differences that may otherwise be masked in aggregate analysis. This slide summarizes several key limitations of the proposed study along with strategies to mitigate them. Self-reported data bias. Participants may underreport clinical conditions or health behaviors. To address this, self-reported data will be supplemented with electronic health records, confirmed diagnosis whenever possible. Misclassification of coronary artery disease risk. Current atherosclerotic cardiovascular disease risk equations may underestimate cardiovascular risk in Hispanic adults. Mitigation strategies include performing subgroup analysis and exploring alternative and culturally adapted risk prediction models. Cross-sectional design limitations, if applicable. Cross-sectional studies cannot establish causality. The study will clearly state temporal limitations and recommend longitudinal follow-up to examine causal pathways. Hispanic population heterogeneity. Hispanic Latino groups are highly diverse in ancestry, culture, diet, migration, history, and socioeconomic status. The study will implement stratified analysis by Hispanic subgroup and acculturation level to account for this variation. Social desirability bias. Participants may downplay unhealthy behaviors due to perceived judgment. Mitigation strategies include using anonymous data collection and validated psychosocial or behavioral measurement instruments. These future research recommendations build on the expected findings of the current study. Longitudinal cohort studies needed to understand how sociocultural and psychosocial stressors influence cardiovascular disease progression over time, helps identify long-term risk trajectories, risk prediction validation studies. Current ASCVD calculators often underestimate risk in Hispanic adults. Future studies should refine or recalibrate these models for diverse Hispanic subgroups. Community-based intervention trials should focus on culturally relevant nutrition, stress management, and physical activity programs. This can help reduce disparities in preventable CVD outcomes. Health services research needed to examine barriers to timely myocardial infarction treatment, revascularization, cardiac rehab participation, and medication adherence. Helps to identify structural or systemic gaps in care. Geographic environmental studies. Border communities and Hispanic majority regions face unique structural stressors. Environmental and geographic research can identify location-specific determinants of CVD risk. Overall, these future studies would deepen and extend the findings of the proposed project. For instruments, the healthcare system's electronic health records, ICD-9 and ICD-10 codes, social determinants of health questionnaire.
For the personnel and role, we'll have a principal investigator. The qualification will be a doctorate in health science or public health, and their role will be to secure a grant for the study, IRB submission, and study oversight. Epidemiologist will have a master's in epidemiology or public health, and their role will be for IRB submissions, oversight, research conduction, and analysis. A research associate with a bachelor's in science will be needed for a chart review and data refining. A biostatistician with a master's in statistics or biostatistics will be needed for data analysis and the statistical analysis. A data analyst or IT personnel would have a master's in information technology and will be tasked with the electronic health record initial study population pool. The timeline for this study, the regulatory part will come first, and this would include developing the study design and submitting it to the Institutional Review Board of the health system. Population identification will come next, and that will be data analytics is given a set criteria to identify the study population for the electronic health records. Manual chart review is conducted to apply inclusion and exclusion criteria for the different stages of this retrospective study. Retrospective research will include execution of the study design and data collection. And then finally, there will be the data analysis of the study findings. And that's what we have today. And that's our references. Thank you.